This is Taya reporting for the Real News Network in Baltimore City, Maryland. I'm standing outside a Baltimore-based treatment center, ground zero in our country's battle against opioid abuse. But amid all the public concern, the question remains, does the strategy touted by politicians actually address the problem? Or is all the public hand-wringing about what to do to fight addiction masking a bigger issue, the culture of the war on drugs? To answer this question, the Real News will be talking to people with a first-hand perspective on the problem, medical professionals and addiction workers and people fighting it in their own lives. Our first interview is with Marion Currens, a woman with over 40 years experience in the field, who has a firm grasp of what does and does not work when it comes to opioid abuse treatments.
So Narcan was, the price of Narcan actually was tripled recently by the pharmaceutical company that holds the patent for it. Has that affected your ability to give out Narcan to the people who need it?
We in Maryland are really blessed that Medicaid will cover Narcan. So thank goodness. There are several different products of Narcan. Some that are very difficult to use. You have to take pieces apart and put an atomizer in, and the atomizer was recalled, so we don't do that anymore. The product that came along was a really cool product, and it was called Ivzio. And the company gave us 500 doses, which I gave out to my staff, and it was for free. To buy the Ivzio, it's a couple years ago, was $500, but they gave it to us for free. But it got our patients, they liked it. Pop it on the leg, and it talks to you. That product right now, I checked with our pharmacist just last week, is $4,500 if you would buy that medication today. So it's just crazy. One of the things that in my particular office, we were going to go in, they're going to tear down our building. And so Dr. Hayes and I, we decided we're going to go into the neighborhood and we're going to try to rent a building downtown. Went to at least 20 different buildings that were up for lease and say, we want to come here and we want to treat our patients here. Yeah, okay. What kind of patients do you treat? And I told them I treat patients who have substance use disorder. Nope, not here, not in my backyard. The NIMBY phenomena. We were turned down 20 times in Baltimore City. We could not find a place where we could put up a program to be able to help our substance using patients. There are lots of different programs that are opening up right now. Why are they opening up? How do they get to open up? And that's because they don't always tell the community until it's too late.
What are the barriers to addiction treatment? What prevents people from getting help?
The insurance company doesn't consider heroin as a medical necessity to admit you to the hospital. So they say, okay, go find treatment. All right, it's midnight at night. Where are you going to go? So we have an office across the street, so we open at 6 in the morning. The emergency room usually lets their patients stay there till 6 o'clock. They walk them across, and there we are, ready for them with open arms to see our patients.
Some people say methadone and other forms of opiate maintenance are just as bad as heroin, that the people aren't really getting sober, they're not in recovery. What do you say to those critics?
I've heard that so many times. And again, it goes back to my nursing. I believe that addiction is a disease. It's a disease that needs to be treated. And it's a chronic disease. It's not something that goes away. Sometimes people relapse, but that's part of the process of recovery. So if you're on a medication, it's okay. If I told you you had high blood pressure and you needed to be on blood pressure medicine, what would you say? Well, I take it, I have to, because it's what I need to manage my disease. There's no difference between methadone or buprenorphine. I think that some people don't act well on methadone, and that makes a bad stigma in the neighborhood, but those are more of an exception to the rule. And many people, if you're managed correctly, if the healthcare provider is giving you good care, there's no way you can tell a person's on methadone. You should not. That patient, I have people that have been there with me for 30 years. You could not tell they're on methadone. They go to Annapolis with me. They hold high-ranking jobs. They're public officials. They're nurses, and they're in treatment. But they're healthy, and they're going to stay healthy with the right treatment for as long as it takes.
Some people believe that addiction treatment centers like methadone clinics create problems. They don't want them in their neighborhood. How do you respond to those people?
And I would say to them, in that association meeting, I would ask this, do they know anybody that's ever needed treatment? And in that room, you won't find anybody that hasn't known somebody that needed treatment. There's been more deaths, and I have some of the statistics here with me, about how many lives have been lost in the past year for heroin overdose, prescription drug overdose, for unnecessary loss of life. I think there's a stigma against methadone, as you mentioned earlier. People are afraid of it. That's because they don't know. They only see some people on the corner that may not be acting as appropriate as they should be. But education, inviting them into the programs, letting them see, letting understand that medications are safe.
What do you want the public to know about opiate addiction and addicted people?
Treatment works. You have to allow the patient to open their lives, go to treatment. It's not about what mom wants, what grandmom wants. It's got to be about what the patient needs and what the patient actually can follow a life of recovery.
So the city has a predominant, almost more than the majority of methadone clinics. Doesn't it seem one of the reasons people in the city are resistant because we in the city have the most? And why are the most of them in the city?
There's a lot of them in the city, isn't there?
Yeah.
And a lot of patients that attend them. But again, Baltimore City is a very impoverished city. It's a very, not a lot of economy in our city. And that's what breeds some of the addiction in our community. So as I don't want a lot of, I want recovery, and the recovery goes where the patients are, and they're here in Baltimore City. And there's a lot more growing in the county too. There had to be 3 of them opened up in the past month in the county. So it's an East Coast phenomenon.
Most of the money though still goes to law enforcement. Do you think that's a mistake?
I think we have to treat our patients, not jail them.
Do you think the war on drugs has been a failure?
I think that not a failure too much as I'd love to see it so much better. I think there needs to be treatment behind the walls. I get very, very upset when I do have a patient who is on methadone or even buprenorphine who becomes incarcerated for whatever reason, that they can't get treatment. That's just pulled right out from under them.
So that is true. They can't get methadone and buprenorphine when they're locked up?
Absolutely. There's only 2, I think 3 now, systems that give methadone to their patients when they're incarcerated. Baltimore County will not. If you get arrested and put in Baltimore County, they put you on their version of a 3-day taper, not using methadone. Baltimore City does keep your patients on methadone. They'll call me and say, Marion, I have Joe in incarceration, and send me a confidential signature, and they'll continue that patient on methadone while they're incarcerated in the city. And in Annapolis is the second place. But every other place that you go to, they will not continue them on their medication.
And what about buprenorphine?
No.
None of them?
No.
So the people who end up with buprenorphine in jail go cold turkey?
Yes.
What kind of effect does it have on the patient?
It's miserable. But as I said earlier, if you have a patient who has a heroin problem and they go to the emergency room, the insurances do not consider opiate dependency as a medical necessity. So they will not admit you to the hospital unless you have a life-threatening illness. That would be an alcohol withdrawal that might give you seizures, or a benzodiazepine withdrawal like Ativan, Valium, Xanax that might give you seizures. Those are the things that will put you in the hospital, that will meet the medical criteria. But opiates alone, according to the DSM criteria, do not meet the medical necessity for an inpatient admission.
So even given the opioid crisis and all the publicity, when you go to the hospital with an opioid emergency, it won't be treated as an emergency? Is that what you're saying?
That's what I'm saying.
Is that wrong?
I think that, and again, our state of Maryland is doing something absolutely phenomenal, and that they are opening up in July. They're allocating more money to be able to put in for residential treatment facilities. So we'll be able to get more facilities, not in the hospital, but in a residential treatment facility. Things changed a couple of years ago when we changed from an MCO to an ASO, and the IMD waivers, a lot of different numbers and letters that are confusing sometimes, but what it meant is that inpatient rehabs weren't covered by our Medicaid system. So they've made some changes, and they're with a lot of pull in Annapolis, and our legislators were going to be able to get a lot of that treatment back.
Delegate Moyheim, proposed a law last year to give people a place to go and take their heroin that's safe, that's clean, get clean needles. Do you support that, and what do you think of that idea?
I've seen it. It's in Vancouver, I believe now, and over in Europe, and it seems to be very successful there. I personally have a little scared about it. I would not want to be the nurse that works in that particular facility, but I don't know enough about it to be able to say that I would support it. I was a little afraid of the needle exchange when I first learned about it. I go, really, what is that? But then I worked the needle exchange van, and I was in the vans on the corners, and I have the patients coming into the van, and how happy they are, and how happy I am to be able to give them needles that are clean and safe. It's better than treating them when they're dying of HIV. In our particular treatment program, 53% of our patients on methadone in our program are hepatitis C positive. For a while, that was almost a death sentence itself, like HIV was. Only 3% of our patients are HIV positive now. And so they've learned to be able to have good behaviors. And so I believe that the methadone or the buprenorphine has decreased their risk of other communicable diseases.